answer. We have a couple things carried forward from this morning, and then we'll move to the discussion questions. So perhaps first I ask a question in regard to the higher prevalence of DKA and the possibility that that might be a subset of patients who are on very much higher doses of Afrezza, and the question of whether that might identify risk groups. So what I'm really asking for is clarification of the data in case I misunderstood the data.
And we understand your question regarding DKA, and we'll ask Dr. Nickham in to address your question.
Hi. So there were 13 cases of DKA, as you pointed out, and you mentioned about 200 units on average dose of those patients per day. But I just want to clarify, those 200 units is from the previous Medtone, which converts into 110 units of currently available Gen 2 inhaler. So can I bring up the slide, please? So I will show you those patients who were in less than 200 Medtone doses in those two studies with type 1 diabetes who developed, and I'll also show you in the slide the new study 171, which was conducted with Gen 2. As you can see in the slide, 009 study, which is on the left, a patient with a mean daily dose of less than 200, out of those, 6 patients developed DKA, and those were about 200 or more, 2 patients developed DKA. Similarly, for 030, you can see there were 3 patients and 2 patients above or below and above 200. The study 175, which is conducted with Gen 2 inhaler, and this is equivalent dose, 200 converts to 133 units. And out of 127 patients who were under that dose, nobody developed DKA, and those about 233 units, or equivalent to 200 units in the old study, 41 patients, nobody developed DKA. So what I'm trying to say here is it's not a lack of efficacy which turned patient into diabetic ketoacidosis. All these patients had some precipitating event where they missed their taking their regular insulin, including basal insulin. And in some patients, actually, they had hypoglycemia within 2 weeks before and 2 weeks after. So further suggesting it was not a lack of efficacy at the time, it was something else.
If I may interrupt, though, those data don't resolve the concern for me, because when I performed a calculation on the 9 subjects who did not have a seemingly very evident explanation for their DKA in terms of not using the insulin correctly, for example, the mean that I calculated was 200. So looking above and below a threshold of 200 is not going to parse those patients against the mean for the total population that you've reported, which is closer to 100. When I look at the data that are on the slide, I see no DKA under circumstances where it appears, I think, because you've used a lower cutoff, that probably the insulin doses overall are lower. So I find myself wondering whether we have a different set of patients in the 171 trial that has made it so we can't see that same phenomenon. And again, I'm not trying to make difficulty for you. I am concerned that there may, or perhaps I'm enthused, that there may be an opportunity to identify a subset of patients who should either have greater caution or perhaps are not good candidates for Afrezza. A subset, not all patients. And so presented this way, it doesn't really resolve that issue. And so what I'm really getting at is it true that the 9 subjects who I spoke of with DKA had a mean of 200 units of insulin per day, and that the mean of the total population was 100 or 110?
Right. So
that perhaps would be the best we can do if that's where we are with the data.
Bring up the previous slide. So let me bring up the slide. What I'm going to show is the mean daily dose of those 13 patients by mealtime, as you can see up here. On the top row shows the mean dose by different meals, breakfast, lunch, and dinner. And in the parenthesis is the converted dose into Gen 2, which is a currently used and to be marketed product. As you can see, mean dose is per meal is about 35 units for those patients, which is approximately 2 cartridges. And I'll ask And I asked Dr. McGill, who is an investigator, who can give some more perspective about those patients.
Okay, again, only if it's going to really provide clarification, because time-wise I want to keep us moving. So if there's more information that'll help clarify, I'm very interested, but otherwise I want to keep us going here.
Right, we're fine. We've answered the question, sir.
Okay. Dr. Stoller, you had a carry forward on clarification also.
Yes, a couple of questions about spirometry. I guess I'd ask the sponsor to clarify some of the details about the quality control. What was the quality control methodology on spirometry, and what were the results of quality control, number one? Number two, stratifying with regard to 030 and 171, which are the data you've shown on pulmonary function tests by U.S. versus non-U.S. centers. Then I have one or two very quick follow-up questions to those.
Okay, and I'll ask Dr. Amin, our pulmonologist, to return to the podium to address your question.
So Mannkind instituted a rigorous and standardized pulmonary testing and quality control program. We involved more than 115 PFT labs globally, and all the labs were selected and trained on-site by the trained certified technologists, and they are required to do at least 10 patients with showing variability of less than 4% in FEV1 before they can participate in the clinical trials. In addition, all these labs are required to do weekly syringe linearity test and also syringe DLCO test, and approximately every 4 weeks they have to have DLCO simulations test. In addition, in every lab required to do biological quality control 2 non-smoking healthy subjects per PFT lab, and their ranges were set for the first 20 acceptable tests. If they perform those 20 acceptable tests, then they're allowed to continue as a biological control. And those biological control reports were provided weekly, was uploaded centrally to a central blinded reviewer who look at it and see the variability. If there's any drift in any of the parameters, the labs will be retrained on an ongoing basis. So our coefficient of variation across 115 or more PFT labs over 6 years period was about 3.24% for FEV1. And as you know, reported coefficient of variability in healthy subjects varies from 2.56 to about 5%. So it was pretty tight, well-controlled or well-monitored quality control program. Now let me show you the data, what you want about study 171 by region. And as the slide comes up, I'll show that we looked at very carefully about various regions. The trial was conducted in USA, Eastern Europe, and also Latin America. And we did not see any meaningful differences in terms of the changes in lung function. Please, slide up, please. So if you can read the slide, top is the USA, middle is the Eastern Europe, and the bottom half is from the Latin America. There were a few patients from Latin America, but if you can look at the change and the standard deviation by region, USA, ex-USA, there was no meaningful differences in terms of baseline values or change from baseline values. And the standard deviation also were within acceptable within each group when you look at it. And I'll give you a minute to go through the slide.
Just one or two other very quick follow-up questions about that. As I look at the data, both in the briefing document on page 191 and on your slide CS16, you know, I'm aware that the FEV1 decline in the non-diabetics, this is in 030, it looks at 1 year it's about, I'm guessing from the scale, about 80 ml, something like that. The question is, were you impressed by that would on average be a higher than expected rate of decline of FEV1 in a non-smoking population? And so I guess were you concerned at all by what looks like a higher than expected rate of decline in the non-treated group that would in turn potentially mask an incremental effect of the drug?
Actually, the decline in FEV1 was 36 milliliter at 1 year, and at the end of 2 years, it was 47 milliliters. So normal expected rate of decline.
Is that
in
right?
average
Well,
health.
Okay, fair enough. It
Sure.
it certainly doesn't look like 36 ml from here, but fair enough. Right. The last question I have on the FEV1 data regards the effect of dropout on FEV1. So we're aware that there were disproportionate number of dropouts in the Afrezza users compared to the non-users. And the question is, many of which were associated with cough, of course. You pointed out there was no relationship between spirometric change and cough, but the question is, are these data somehow censored by selective dropout of the accelerated declines in FEV1 in those patients using Afrezza that would mask a difference?
So we actually looked at not only the safety population, but also completed population, as I showed in my course slide for 030. And the difference at the end of 24 months was in the safety population was 37 milliliters versus completed was 38 milliliters. But in addition, we also did sensitivity analysis to account for this dropout, whether that has any impact or not. Can you bring the slide up, Les? So what you see in the top row is a mixed model repeated measure, which was the primary analysis for that 2-year pulmonary safety study, which I showed in the 030 study, and which also takes into account some of the missing data or the dropout. The middle row shows the multiple imputation done in all the patients, but also at the time of analysis, at the time point of the analysis, in this case, 2 years, we added 15% penalty in the sense like all patients on the TI, we give additional 15% penalty only on the TI group and not in the comparator group. And again, you can see the point estimate difference is slightly bigger as expected, but not meaningfully different. The last row, actually, we also give imputation at the time of dropout to all patients who discontinue because of respiratory adverse event. We give 15% penalty at the time of the dropout and then carry them forward. And again, you can see the point difference, point estimate difference is slightly bigger as expected, but not terribly worse.
Dr. Wilson, did you have a clarification question carried forward?
I can pass on that. I'll come back later.
Okay, Dr. Swenson?
Yes, my question was about some aspects of the reaction to Afrezza, and I asked about whether you had done any bronchoprovocation studies to look at this issue. And then just as a second question, regarding the hypoglycemic episodes in the patients on Afrezza, was there any relationship to those hypoglycemic episodes and the concurrent, whether they had concurrent URIs or something that might change the absorptive characteristics of the airways?
Yes, well, Dr. Amin, again, we'll return to the podium and address your question regarding, after initiating, did we do any methacholine or Pravachol challenge testing in our subjects?
So we did not do in clinical trials any methacholine or mannitol challenge test after patients are already on the treatment. But only thing I can say from the clinical data, except for 2 patients who developed bronchial hyperreactivity, we did not see any patient developing asthma during the clinical trial. It doesn't answer your question, but I think it tells clinically it may not be possible. Referring to your second question about URI and hypoglycemia, about 4.4 patients in the clinical trial had a URI out of 3,000 patients, and only 1 patient who had a DKA had associated URI. So a lot of patients had a URI as we expect, and very few, if any, had any glycemic impact on the glycemic control. We actually did the pharmacokinetic study also in patients who has a URI and looked like the serum insulin concentration and also after the resolution of URI, and there was no difference in the PK parameters in the insulin concentration at all.
Dr. Wilson, were you signaling that you in fact did want to follow up on that question?
We were on pulmonary, so I can ask my pulmonary question. So 2 related. One, has the excipient changed at all over the course of the last several years? And has there been any experience with individuals stopping the inhaler, having a lapse, so to speak, and then re-challenge? Does the bronchospasm type of problem come back again?
Yes, sir. No, the excipient has not changed. FDKP has been in the product since its inception, and the powder itself, the formulation, has not changed throughout the entire phase 3 development program. And I'll ask Dr. Amin again to address your other question.
Yes, so we have experience in our clinical trials that patient actually in the clinical trial instruction was if they have respiratory infection or cough, they want to temporarily interrupt for a few days, TI, and then restart. And we have not seen any, when they restarted, any change in clinical symptoms. Actually, many patients who interrupted treatment because of cough and then were re-challenged by restarting a few days later, they did not report cough.
Dr. Wilson, follow-up.
As a follow-up, were any patients admitted to hospital, then received conventional therapy, then restarted on the inhalation therapy?
There were many patients who were hospitalized for a variety of reasons, myocardial infarctions or even those patients with DKA. And except for 3 patients with DKA, they went back into the inhaled therapy.
Ms. Hilaire, did you have a question for clarification you wanted to ask?
I have one question with regards to effectiveness and a few questions with regards to safety. Speaker number 1, the public speaker number 1, has spoken about lowering the dose of Afrezza, and I was wondering if there were other cases similar to his, and how many cases were there where instead of increasing the dose, you lowered the dose, and is it more frequent for type 1 or type 2 diabetes?
I'll ask Dr. Bregman from the clinical unit to address your question about lowering the dose of Afrezza.
And I apologize, but I'm going to need to ask you to clarify. I'm not exactly sure what you're looking for.
I was wondering if, because of effectiveness of Afrezza, is it possible to have lowered or readjusted dosage of the medication?
You mean with respect to the dose that a person might have been taking on the injected insulin?
More on the Afrezza.
Oh, okay. For sure, now that I understand. Subjects would be monitoring their glucose, and they can adjust their dose up or down. And in the clinical trials, there were algorithms to guide this, and in clinical practice, we would expect that just with other forms of prandial insulin, based on a day-to-day or meal-to-meal basis, you could adjust as you feel is appropriate.
Certainly a clinical perspective to that could be brought by Dr. McGill, who treated patients in both 175 and 171.
So I appreciate that there are many endocrinologists on the panel and that some of you are not. Our patients adjust these patients are on what we call intensive insulin therapy, which means that 4 or more times per day, they check their blood glucose and they do something. So they adjust their dose actually according to their blood sugar, according to their expected meal intake. They adjust it at least 3 times a day, and then we look at the week, we looked at it every week, and then we made a little bit more of a global adjustment. So both things happened. The patients did it, meal to meal, and then both by a very structured algorithm. And I, for the statisticians in the room, these structured algorithms sound great. Why didn't everybody get down to an A1C of 6.3? It's because when you have a structured algorithm looking at 3 days worth of values and you get a 210, a 244, and an 89, how do you adjust insulin with that? And there would be times that the doctor would override for safety, even if there might be a recommendation to go up. So safety was the paramount concern. Everything else is secondary. Thanks.
Thank you. Dr. Thomas?
There were two questions I'd see if you had data for, and if you do, that'd be great. If you don't, that's fine. The first one was related to my question earlier, data on multiple inhalations versus one inhalation on coefficient of variation within a patient.
Yes, sir, we do have that data. We conducted a study 142, which looked at one 20-unit cartridge and two 10-unit cartridges. The coefficient of variation in that response, both for area under the curve and Cmax, was 41% for the single dose and 44% for the double dose.
Okay, thank you. And the second question was actually related to the slide that you had 39, which was the hypoglycemia slide. You had separated the event rate by achieved A1C. I was curious to see if you have data that was related to the decrement in A1C. So what were the hypoglycemia rates based on how much the A1C was lowered between the two groups?
Yes, I understand, and we have done that analysis, and I'll ask Dr. Bregman to return to the podium to address your question.
Yes, we have done that analysis for the data, again, in trial 171, and it is a similar pattern. Slide up, please. So basically, on the x-axis, there are a range of changes in A1C from baseline to week 24, from a decrease of 0.6 to an increase of 0.2, and you can see that consistently going across these various deltas, there is a consistent hypoglycemia advantage in favor of TI.
Thank you.
Dr. Cook?
My question is related to the lung cancer risk, and I have a question about some of the preclinical data. So you've done some studies in rodents looking at the malignancy risk of this agent, and you had done some inhalation studies in rats that didn't show any difference. But then you did the carcinogenicity studies in the RAS-H2 transgenic mice, which are at a higher baseline risk of malignancies, including apparently lung cancers, which would seem to be a very good model. But you chose to do subcutaneous injections in that higher risk mouse model. And I'm just wondering if you've done any inhalation studies, longer term inhalation studies in that model, because I think that would be a good model to maybe look at this risk question of the high local concentration in the lungs.
Understand your question, and I'll call on Dr. Pat Frank, our toxicologist, to address your issue.
I'm Pat Frank, consultant at Mannkind with no financial interest. The short answer is no. We have not conducted longer than 6-month studies. As you may know, the FDA reviews carcinogenicity studies before the sponsor starts them, and these studies were, of course, submitted to FDA and approved. 6 months is the standard for the RAS model. I would like to mention, if I could have slide up, please, that in this study, these mice carry 3 copies of the oncogene, of the RAS oncogene, which also carries an endogenous promoter and enhancer in that construct.
Just to make sure you're addressing my question, the question isn't so much the duration of the study, it's the route. It's the route.
Right. And so, regardless of the route, the enhancement of lung tumors is present. The reason we chose subcutaneous, first of all, because of ease of administration to mice. Rats are easier to get for inhalation. The point was that we could go to much higher levels of technosphere particles. I believe that we're limited by technosphere insulin, both by inhalation and by subcutaneous, because the animals die of hypoglycemia if we go too high. However, we wanted to get a really whopping good dose in of the particles. We were able to go up to 75 milligrams per kilogram per day in these animals. By inhalation, we're limited by the feasibility of how much powder they can actually inhale in a chamber. So that was the limitation on the study for why we chose subcutaneous.
Okay, thank you. Now, as your choreographer, I'm anxious to move to the discussion questions so we have time speaking to the panel here. So there are a few more clarification questions, but again, I'm asking you to please keep them brief. and focus on things that are important clarifications before we get to the discussion questions. So next would be Dr. Hendricks.
I just had one brief question. I'd like to know more about the weight changes. I mean, you told, so do you have any detail on that? Can you show us a spectrum of the weight changes?
Yes, we do, and I'll ask Dr. Bregman to address that question.
One point I'll make while we're waiting for the slide to come up is that the weight changes, like the hypoglycemia advantage, is independent of hypoglycemia, and we were able to show that by the ANCOVA model that was used for showing the weight change was had terms for A1C in it, and also when we looked at different ranges of changes in A1C, we saw the hypoglycemia persisting. Slide up. And actually, that's shown here. You can see that the weight change is independent of the weight when we look at the ANCOVA model, either adjusted or unadjusted by A1C. And to directly answer your question, there is some of the range. Basically, what I can give you is the the mean. That's really, I don't have a distribution or anything like that.
Thank you.
Ms. Killian, you had a question?
Yes, actually, I had a question that also related to the weight gain, or the weight differentials. As I understand it, there was some weight gain showed when you took people on Afrezza who had been on a placebo or versus placebo. So that makes sense to me because when you initiate an insulin therapy, you unfortunately expect to gain some weight. What I found more interesting is that when you had people who were on insulin and they went to Afrezza, they showed some weight loss. And I was wondering if you knew what accounted for that differential.
And again, I'll ask Dr. Bregman to address your question.
Well, first of all, in the placebo-controlled trial, we believe that the patients who were in 175, the ones who were randomized to placebo, lost weight because they were on placebo and were measuring their blood sugar, and we believe that they became more aware of the excursions in their SMBG, and that probably led them to exercise and diet. When we looked at the comparison of injected insulin to inhaled insulin and why there was a weight differential, I think the reason, well, we think the reason, and again, it's speculation, is that given the lower risk of hypoglycemia, there may be less defensive snacking. That would be one potential, reason.
Can I have a quick follow-up there? Just did you find that on Afrezza that with a more rapid response that they were actually using less insulin that they might have been using in an injectable form? Or did you not look at that?
We did not really look at that.
Dr. Swenson?
Yes, I've returned to the lung cancer. And just a question, all the models you've used have, I believe, are in animals without tumors already present. And I wonder, did you consider looking at animal models, nude mice and other things where one can develop cancer and then test exposures such as inhaled insulin? It would seem to me that that might be a better test of the issue over time, since many of these patients probably that develop cancer in the observation periods for both compounds probably already had tumors in very, very early stages. Pre-malignancies, however you want to term them.
No, our study in rat, the 104-week study in rat and the 6-month study in transgenic mice were in tumor or neoplasm naive animals. We did not study it in those in which they had been initiated in neoplasm.
Okay, so I think we'll now proceed with the questions to the committee posed by the FDA and the panel discussions associated with those. I'd like to remind public observers that while this meeting is open for public observation, public attendees may not participate except at the specific request of the panel. So if we could move to discussion question 1, please. I'll read this question. Question 1, trials in type 1 diabetes demonstrate that Afrezza provides numerically and statistically less hemoglobin A1C reduction than a comparator subcutaneous insulin. Discuss whether the applicant has demonstrated that Afrezza is an effective treatment for patients with type 1 diabetes mellitus. In your discussion, please address each of the following issues. A, the impact of inadequate treatment optimization in the control arm on efficacy determination. B, the impact of missing data on efficacy determination. C, the relationship between Afrezza's clinical pharmacology, for example, extent and duration of action, dose response, inhalation flow rate dependence, to its effectiveness as a prandial insulin. D, your level of concern with regard to how differences in efficacy will impact disease-specific risks, for example, risk of diabetic ketoacidosis, beyond achievement of therapeutic goals, i.e. prevention of diabetes-related complications. E, the importance of having an alternative route of insulin administration available. And F, comment on whether Afrezza is an appropriate substitute for subcutaneously administered mealtime insulin for most patients with type 1 diabetes or for a specific subgroup of individuals with the disease. If you believe the latter, describe this subgroup. So I'd like to open this for comment on these discussion points by the panel. Dr. Britton.
Okay, I guess obviously I'll be talking more from a statistical perspective. I mean, obviously we know from the data that in terms of hemoglobin A1C, as the question poses, that it's not as good as the comparator. So I think that's pretty much a tip-off that this probably not for everyone, not for someone who wants to maximize their A1C, or actually minimize, I guess. And I think it's pretty clear, based on what we heard this morning, that it's better than placebo. And I believe that from the conversation we had with the FDA earlier, that there's a feeling that maybe the true difference between the comparator and placebo is really greater than 0.8, or could very well be greater than 0.8, in which case 0.4 might be kind of a top standard for the non-inferiority margin. But so what we don't know, we don't really have clear evidence that the efficacy is within 0.4 of the comparator. The results are very borderline at best. The sensitivity analysis, which is kind of almost a worst case, or at least a pessimistic case, had the margin, had the confidence bound at 0.48. So obviously we don't have a lot of confidence in the 0.4, although the primary analysis, which does deal with the missing data, under some assumptions was within the excluded 0.4. So it's borderline in terms of the pre-specified 0.4. So I guess then the question is, can there be a little latitude about the 0.4, given the possible advantages with the hypoglycemia, although I agree there's I'm not completely sure how to interpret the hypoglycemia data, but also in terms of the ease of administration, et cetera. So I think that I would be kind of inclined to be a little generous about the fact that the tough, pessimistic sensitivity analysis didn't exclude 0.4.
Dr. Thomas.
So just a few comments. In terms of the treatment optimization and control arm, I was a little surprised that when reading the documents, that there wasn't more of a drop and the dose wasn't intensified as much as I would expect in a trial. With a forced titration, you should actually be advancing. I can understand safety issues, but numerous trials have done forced titration and achieved more of a dose escalation. And if that's the case, there's less of a difference. So it actually biases you towards a result that would show that it isn't inferior. So that is a problem. The other things I would just say is in terms of having an alternate route of administration for insulin, I think for someone with type 1 diabetes, the increased cases of DKA and also the need to have some other type of treatment in some of the patients beyond Afrezza, you would need to still have short-acting rapid insulin injectable forms available for use. The last things I was just going to comment is which patients are the best patients for this. I do think there are subgroups that make the most sense. You know, the nice thing is that it is rapid acting and seems to have potentially less hypoglycemia, shorter acting. So this might be an ideal dose of the type of insulin take in between meals even, when your glucose is rising, and instead of taking injectable insulin where there's stacking and prolonged hypoglycemia after taking an additional dose, you might want to take this because the duration is shorter, the onset is quicker, and maybe it'll get you down to target in between meals, treating that postprandial hyperglycemia. Other patients that might benefit from this are people with gastroparesis, where there's always difficulty in timing the insulin administration to the peak glucose increase. You know, you could follow this along with a rapid-acting insulin that's injectable. It's hard to do. With this, it might be a better fit. And the last thing is really more of convenience or in terms of privacy. One of the issues that we get with patients, or especially when I treat them, is many patients will sometimes miss a dose at lunch or work because they don't have a place to store their insulin properly, or they're afraid of their coworkers finding out about their diabetes. You know, this is something that at least maybe they don't take on every meal, but at meals where they're out of the house or at work, they might want to take this type of insulin for those reasons. Take care of a lot of people who work in factories in Detroit and around the area, and there really isn't good storage areas where you can keep insulin reliably without having it degrade. The last thing I just want to do is actually a comment from Dr. Britton as our statistician on the panel. My recollection is if you're going to do the MITS model of repeated measures, the data really has to be missing at random or completely at random. And if it's not, then it doesn't really hold up in terms of its validity. And there are concerns that I have that much of the missing data really isn't completely at random. We know at least several cases were discontinued for efficacy, and some of the other cases may be similar or mixed in terms of not really being random losses.
Dr. Britton, did you have a follow-up on that?
Just a little bit. I don't want to get into really technical stuff here. It doesn't need to be missing completely at random to be addressable by the mixed model approach, but it can't be. I don't know that I'm going to be able to explain this, but it's sort of a middle ground, what they're assuming, the assumption that's being made, that you're kind of taking into account what you do know about the patient before they drop out. And the other, and I mean, obviously they did the sensitivity analysis, which was pretty pessimistic, under a pretty pessimistic assumption, and that's when the bound changed to 0.48. So there is no right answer here. All we know is it's a borderline result.
Ms. Killian.
So from a patient perspective, I've always found that physicians are much more enamored with the hemoglobin A1C numbers than patients are generally, to the chagrin of my endocrinologists. But I find that as a patient myself, and I think I speak for the population in general, the fear of a hypoglycemia, I mean, we're talking about an immediate consequence of your condition versus a sort of long range, if my numbers are so high, I run at risk for these other things. I mean, the idea is we have to survive the now in order to worry about the later. So there's this tension between patients and doctors about the hemoglobin A1C, I think. And I think that that should not be forgotten or underestimated. Because when you talk about what that number entails at the end of 3 months when you're getting your, you could be buying a pretty decent hemoglobin A1C with a series of highs and lows. And that is something that affects the patient every single day. So here's what I know. Diabetics dance with the devil every single day. Our lives are a series of peaks and valleys. That was made very clear to me when I went on a CGM and I saw how very little time I spent in zone. In fact, it was transit time. It was always coming in and out, coming in and out. Very, very frustrating. And trying to deal with that, and dealing with the burdens of a disease every day, trying to get it right, and failing to manage it, and then having a number 3 months later telling you just how poor a job you may have done of that, and finding that to be the measure of whether you're successful or not is extremely frustrating to patients, and it's not really reflecting what they're dealing with every day. Because what the message that the patients get are that the patients are failing. Patients are failing. And it's not the patients that are failing, it is patients being failed by their treatment options. And that's something that I think is very important for us to consider when we're talking about what these treatments do and what options they provide. And they're not going to be perfect for everybody, but they're going to offer patients options that weren't available before. And those options are very important to patient empowerment, patient result, patient compliance, all of these things that are not measurable like a hemoglobin A1C, but are incredibly important to patients who have the disease.
Thank you. And Dr. Wilson.
Thank you. So to follow up on what was just said, I think endocrinology, we're used to measuring everything we possibly can and titrating even more things. And there's a tremendous gap, as Ms. Killian was just mentioning, for some of the things we have tough time measuring. And one of them is patient acceptance, patient hopes, and how we can work with patients as providers. One of them I think we need for better glucose control is we need more assessments of adherence concepts. I'm just saying this partly for the FDA as we move forward in the glycemic control arena. Quality of life for patients, how well they can really adhere to whatever they're supposed to be doing as part of their contract. Another group, Dr. Thomas mentioned some of the barriers to patient use. I have the same when I take care of patients in the VA, and I mentioned a couple of more. Patients with limited dexterity, can't use their hands very well. To use a puff device would certainly be a lot easier than drawing up insulin. Some patients have to have pre-filled insulins dropped off in syringes, kept in the refrigerator for a week at a time. All the endocrinologists in the room know this, but hasn't been mentioned up to now. And the other is people with decreased eyesight. They also have trouble drawing up the amounts of insulin and having a quicker delivery. So these are some of the other things that I think certainly, that's why many endocrinologists and the patients who, at the open public hearing, were talking about things that we weren't measuring, and I think we should measure them in the future in their qualitative aspects of diabetes care.
Dr. Calhoun.
Thanks. Let me take a stab at a couple of things in point C. The question on inhalation flow rate dependence, if I read the briefing document right, this device needs 20 or 30 liters per minute flow rate. That's trivial, and there should really be no problem in achieving 20 to 30 liters per minute flow rate, particularly if you're excluding folks who've got pre-existing respiratory disease. So I'm commenting on that only to say I don't think it's really an issue. And with respect to the clinical pharmacology, not being an endocrinologist, I'm a little out of field here, but I wanted to just make sure I understood the agency's position on this. When Dr. Jain talked about the clinical pharmacology, the onset was quicker and the offset was quicker than short-acting insulin. And I took from your presentation, and maybe I don't want to mischaracterize you, but I took from your presentation that you thought that that was a disadvantage. But in terms of prandial insulin delivery, that would seem to me to be an advantage, particularly if it then culminates in a somewhat reduced risk of hypoglycemia. Thanks.
And Dr. Shamblin.
Well, just to pursue the same point, I thought the clinical pharmacology data were encouraging, and in particular, I think the emphasis on a somewhat flat dose response curve, to my knowledge, other insulins similarly tested, this is a pretty elaborate protocol that they used here, showed the same thing. I found a paper with glulisine that was quite similar, and that's been the experience in talking to other people who use clamps. So I'm not sure that I see that kind of flat dose response, or what is a tapering dose response, as being an issue. And besides, unlike other medications, we're not dosing insulin based upon a single fixed pill, but we're adjusting insulin to the outcome, and I think that's what you would do in this circumstance, regardless of the PK/PD difference. You had an answer for that.
May I respond?
Yes, please.
I'm glad that these questions are asked here. I would like to clarify one aspect that I was not necessarily implying that the earlier peak and quicker offset are bad for this product compared to subcutaneous insulins. I was trying, so once we observed lower efficacy for this product compared to other insulins which we have seen, we were trying to understand what is different between this product versus the previous insulins, and that is what I presented to you. And to address the second question specifically about the dose response, this product has a quick peak and which goes to concentrations significantly high compared to the concentrations which we see with subcutaneous insulins. And the question which we asked to ourselves was whether we will get additional benefit by just increasing the Cmax and not having additional the coverage for sufficient duration, because as you saw from profiles, it comes back to baseline by 1.5 to 2 hours or 3 hours for higher doses. And we in fact did some exploratory dose response analysis where we used Emax model and tried to predict dose response for subcutaneous and Afrezza insulins. And if time permits, we can in fact present 2 or 3 slides from that, if that is helpful to the committee.
Do you feel like it's important to see that? Yeah. I would prefer to probably keep moving so we have enough time for other discussion. If we change our minds about that, we'll come back to it. I'd like to make a couple of comments. I guess from my perspective, I agree with what I've been hearing from pretty much everybody else who's commented here, but I want to express that I still have concerns that while I understand the non-inferiority analyses and things that have been done, I have concerns that the efficacy may be less than subcutaneous insulin. And that doesn't mean that it might not be useful for some patients, but it means that it might be disadvantageous for a number of other patients who may need the efficacy they're getting from a subcutaneous insulin and who they may not achieve that with Afrezza. And so I've not seen data that convince me that that's not the case. I've not seen the study, and if there are data that I'm not understanding, please correct me, but I've not seen data that enable me to be comfortable that efficacy isn't less, and that thus wouldn't be an impact on who this is appropriate for. I think as a specific model or a specific circumstance, and I'm not trying to grind this into the ground, is the ketoacidosis situation. And again, my first comment, I'm really broadly referring to a much larger group of patients, but as I looked at those data, I had concern from the ketoacidosis data that there might be an even more extremely unresponsive group of patients in terms of efficacy that might bring with that a vulnerability to ketoacidosis. And I didn't think we would resolve that today, but I think it's a concern that's present in those numbers. On the more positive side, I've heard about patient subgroups and I share the experience with the subgroups that the other panel members have mentioned where an inhalable insulin in this form of preparation could be very advantageous. I've also had experience with the much more uncommon circumstance of extreme needle phobia. not needle phobia, not wanting to use injections, but extreme needle phobia, where patients who can well understand the consequences of not injecting insulin simply cannot do it and won't do it. And I've dealt with extreme examples of that, and so there's another patient subgroup that I think would benefit, irrespective of whether the efficacy is identical or better or worse. Yeah, Dr. Wilson.
I shared some of the same concerns. One of mine was looking at the graphs, and both the sponsor and the FDA showed data for the 6-week startup for titration, and then further out to 24 weeks. And it appears there's still a fair amount of dose changing going on after the 12 weeks when they should have been stable on the inhaled insulin. So the simple question, is that enough time to get the clinician and the patient sort of on pilot? It's not easy to pilot these patients, but to get them, things are still changing towards the end of some of those periods, and raises the concern that there's a lot of variability. The other one, related to your concern about DKA, is the rescue strategies. For instance, I would think, wasn't there in place a rescue strategy for persistent glucose levels above a certain level? That becomes a mild adverse event that leads to involvement with the clinician who's involved with the trial conduct, et cetera.
So if there are no other comments, I'd like to try to summarize, and then you, the panel, can correct my errors and make additions that you feel are not there. So I'd like to sort of summarize what we've all said. I think, first of all, the panel has expressed the view that there is a very important need for new treatment options. We're speaking in this question of type 1 diabetes. And that means new treatment options in terms of better managing the glycemia itself and better managing hemoglobin A1C to target, but also better treatment options in terms of the various ways that the current strategies for managing diabetes are burdensome or difficult for patients. So there's a very strong need for a new strategy for insulin as well as for other drugs. In terms of the criteria applied to evaluating comparatively Afrezza versus rapid insulin analogs, there's really uncertainty based on the data that we've been able to review. There's borderline, it's on the border in terms of non-inferiority exclusion. It's also the sensitivity analysis data do not resolve the borderline status. So that I think the consensus of the panel is that we're sort of in a border zone for the way non-inferiority has been defined in terms of the studies and the target that's represented. The point was also made that does not necessarily define whether or not Afrezza would be useful and efficacious in type 1 diabetes patients. We have, I think, grounds for uncertainty about its broad application to all patients with type 1 diabetes, but we've identified a number of subgroups in whom this form of insulin might in fact bring a net benefit as compared to the available alternatives. And that includes patients who may have needle phobias, patients who may miss doses of insulin and may miss fewer if they have inhalable insulin. I'd want to stress that we have no data that state that that's the case. We don't really know that they would miss fewer inhaled doses than they do injected doses. Patients who might need insulin between meals, supplemental doses of insulin, it may be more effective under that circumstance for that subgroup. Patients who have visual impairment or manual dexterity issues, it may be beneficial for that subgroup of patients. We've expressed concern about some patients being vulnerable to increased risk, and we've discussed this in the context of ketoacidosis, where there's concern that there might be a subset of patients who either respond less well or are on such a high dose that they're not really getting advantage of increasing doses of insulin, and they may be vulnerable to an increased risk of ketoacidosis. And in this context, panel members have made the point that they would envision patients using Afrezza probably should have available an alternative injectable rapid-acting insulin to be used as a protective agent if they were having uncontrolled glucose levels. I would add to that if they developed a problem with function of the device, for example, perhaps in a circumstance where they couldn't rapidly replace it. In terms of the kinetics, the point has been made that whereas the rapid on-off characteristic, more rapid on-off characteristic than rapid insulin analogs has been discussed at length, that actually that may be advantageous in some patients as well as it may be disadvantageous in other patients. And an important point was made about dose response. We've heard that there's some grounds for some concern about loss of response to higher doses. So there's really no progressive dose response as doses are further increased. But we've also heard the comment that insulin typically is adjusted in dosage in diabetes according to blood glucose levels. And so the lack of a strict linearity over a range of dose responsiveness is probably not critical to the use of an inhaled insulin. In essence, that's not really how injected insulins are managed. It's really done by feedback from glucose levels. So I'll ask the panel, have I left out, or what have I left out that's critical, or what have I said that's wrong? Dr. Britton.
It was a very nice summary, but I think you didn't mention something that I think we should acknowledge, which is that the results in the comparator were significantly better than with the new drug.
Thank you. Any other additions? Then I would like to move, actually what I would like to do is to take a 10-minute break, and then we'll move to question 2. So please be back here at 3:15. So we're going to call ourselves to order again and move on with discussion question number 2. I will read that. Trials in type 2 diabetes demonstrate that Afrezza is superior to placebo but is less effective than a short-acting subcutaneous insulin comparator. Discuss whether the applicant has demonstrated that Afrezza is an effective treatment for patients with type 2 diabetes mellitus. Comment on the specific clinical setting where this agent is likely to be most useful. Discuss your level of concern with regard to data suggesting a less than dose proportional glucose lowering response and its potential impact on achievement of glucose targets in this population. comment on any other issues discussed in the context of type 1 diabetes that you view as relevant to type 2 diabetes, comment on whether Afrezza is an appropriate substitute for subcutaneously administered mealtime insulin for most patients with type 2 diabetes or for a specific subgroup of individuals with the disease. If you believe the latter, describe this subgroup. So I'll open this to comment discussion by the panel. I will lead off because with my own comments, which is that I guess I don't want to restate all that's been said for type 1 diabetes, and a lot that has been said is appropriate for type 2. But there are, I think, some specific things worth saying. I do think that there are circumstances under which in type 2 diabetes Afrezza would be useful. And I think some of them are, as we've described, in terms of patient subsets that may have difficulty using currently available forms of insulin or may be resistant to using currently available forms of insulin. There are reasons, to my mind, for concern about whether they're what one would define as subgroups or whether they're just circumstances or the conditions within type 2 diabetes patients that I think merit careful consideration. One of those is that type 2 diabetes patients often manifest much more insulin resistance than type 1 diabetes patients and thus require higher doses of insulin. And we have reasons for some concern about the effectiveness of Afrezza under circumstances where it's used in high dosage. So I think, if anything, there perhaps is a need for more vigilance in terms of whether or not Afrezza is effective in insulin-resistant type 2 diabetes patients. I think there are concerns in that the typical pattern in which type 2 diabetes patients are treated as they progress to a requirement of insulin is that most often they're treated first with a basal insulin, a long-acting insulin, and then they rely upon their often oral agent supported insulin secretion and lowered insulin resistance to cover peaks at mealtime. And dealing with an insulin like Afrezza that's very short in its duration of action, I think I would have concern that it not be misused in type 2 diabetes, and that is not used as the first form of insulin for those patients when they then have very much uncovered basal insulin levels. And for brevity, I won't go through the data that has raised that same concern about a failure to provide what basal insulin does. So I think that also, in a sense, limits or focuses the way an insulin like this might be used in type 2 diabetes. I could say more, but I'm going to stop if there are some other people here who'd like to make some comments. Ms. Gillian.
So one of the concerns I have when we're talking about the inferiority of Afrezza to subcutaneous insulin is that you're assuming, or I guess we're talking about a population that is on injectable insulin. There's a large population of type 2 diabetics who are not on subcutaneous insulin that should be and choose not to go on it for various reasons that we've all discussed: fear of needles, acknowledgement of failure, the inconvenience, all sorts of other reasons. If there are cultural influences that affect that, all sorts of things. So there's a population that and I think it's for a few years could benefit from being on an insulin therapy who are not on that therapy because they simply do not choose that as an option. Type 1s don't have an option, but type 2s do, and I think that we need to be acknowledging that in terms of giving them something that is less objectionable to them and a little bit easier for them to take up. So when we're talking about what it's inferior to, I mean, I think it may be inferior to injectable insulin, but it would be far superior to no insulin therapy other than basal insulin therapy at all. So we need to keep that in mind when we're thinking about, whether, this product is inferior or superior.
Yeah, and I might just respond that I agree with that. I think that's a very good point, that it's a potentially much larger population. I guess what I again would stress that this is sort of an experience conjecture projection by you and by me and others. We don't really have data that have addressed
Right,
that.
'cause we haven't measured
we
it,
haven't seen the
yeah.
data that have shown us that's what happens or what would happen.
Right, but as we, how do we get the data if we're not, if we're not seeking to measure it? So it's a catch-22.
Dr. Thomas.
So just a few comments. One is, I think many of the features that we're going to talk about for type 2 are really common to type 1. So the only other group I would add, which is an increasing problem, is the patients I have who have type 2 diabetes predominantly, and they need a caregiver, but they're not in a nursing home. We have to do all types of strange regimens that a family member could administer insulin because the patient themselves are unable to do that during the day. And this might be something that another caregiver, like a grandson or granddaughter, might be able to do, or they might be able to do in between shots. So I think that's just another group. I think the real concern that we're having, which is also in the previous one, which is brought up already, is we don't have a treat-to-target trial. And really what you want to know in the end is, it's true A1C is not everything. If you're spending most of your time hypoglycemic and hyperglycemic, that's not a good assessment of where A1C is helpful. However, A1C is what we use in terms of all of our trials for outcomes. So it is an important measure. And if we actually could see from the trials that we're getting patients to the target A1C level, and then we could compare that to the subcutaneous insulin, achieving a significant drop in A1C to reach target, I think all of us would feel more comfortable with those results, whether they're positive or negative, to assess the question. So regardless of whether this drug gets approved or not, there needs to be some type of trial that does treat to target. And it has to be some type of forced titration, whether it's patient-driven or provider-driven, that makes sure that we have that information. Because otherwise, we're having a lot of hypotheses and feelings about what's happening, but we actually don't have the data. So I think that'll be important to do, regardless of what happens with the decision.
And Dr. Cook.
So just another small comment regarding the ease of use and the greater comfort in using this to avoid insulin injections. I think I agree with the other comments that for there will be a number of subsets of patients for whom this will be an easier entry into insulin use, where they may not otherwise have used it, either because of personal reasons or social reasons. And for those patients where they just will not be getting the injections, this inhaled insulin certainly would be an advantage over nothing. But I think the factor on the other side is that if this then becomes another reason to delay injected insulin, that may further delay the better efficacy of injected insulin that would be a negative aspect of this availability. And I think it's hard to balance those two aspects.
Other comments? Okay, so look at that. That's actually Dr. Shamblin. Okay, Dr. Thomas Skin.
No, I just wanted to add on, it's right what Dr. Cook said. Just for type 2 diabetes, because I forgot to mention, I don't think, the trial was an add-on to oral medications. There was one of those in type 2 diabetics. However, most of the patients that I end up seeing that need to start on insulin usually end up on a basal or long-acting insulin, because the fasting glucose tends to be high first, and we have other mechanisms to treat the postprandial. And I know there is barriers to insulin injection, but I'm always surprised, and I'm not surprised anymore, how much that is not a problem with injectable GLP-1 agents, where patients have not actually resisted starting on an injectable. So I'm not sure the barrier is complete as it used to be. I'll just give an anecdote for a patient this week who's on a drug who I won't say, but has a 27-gauge needle. She doesn't like the 27-gauge needle, and I told her, well, that's what the gauge needles were when I was training in the 80s, and they're much smaller now. So the barriers to some of these issues with needle preference and needle phobia, because we used to have very large needles, and now we have 32-gauge needles, which are actually much more comfortable to use. So the barrier for insulin injections is not as strong as I think it was in the past, because GLP-1 agents seem to be quite popular.
Dr. Wilson.
I think building a little bit on what Dr. Thomas and Dr. Cook said, there may be some problems with how this would roll out to clinical care. Now, in general, when patients start insulin, they start with endocrinologists and they start with certified diabetes educators and a rather controlled, explicit education program. It's a lot easier to take a nebulizer or inhaled insulin, and there may be a lot easier paths to start this. And the basal insulin underlying all this, I think, is critical. All these trials have had basal insulin. And the physicians who are not endocrinologists may be in a situation of not using that information as they move forward and prescribing. In other words, prescribing an inhaled insulin with other therapies without basal control, and that could lead to lots of problems, I think.
Okay, so I will try to summarize, and again, look for your help with this. The group feels that many of the points that were already made in regard to type 1 diabetes also apply to type 2 diabetes. Importantly, it's the feeling of the group that there likely are circumstances under which Afrezza would be an effective treatment for patients with type 2 diabetes. But as was stated for type 1, not simply in all patients, and probably not simply as a replacement for other forms of insulin. There was a further discussion of subgroups, which include those mentioned for type 1 diabetes, but mention also was specifically made of the not uncommon circumstance of often elderly patients who are receiving some degree of caregiver assistance, but still living outside of a nursing care facility, where it's envisioned that an insulin with this mode of use could be efficacious and an improvement. Concern was expressed about the potential for use of a sort of more aggressive use of mealtime insulin without adequate basal long-acting insulin coverage, which might come about simply because of the more appealing way of taking this form of insulin from a patient perspective, or the panel expressed concern that, or of simply a strategy of who is instituting the insulin and their sort of understanding of management of diabetes, type 2 diabetes, which when transitioned to insulin often requires and benefits from a long-acting insulin base on which mealtime coverage is provided. Important point was made that we do not at this point have an adequate treat-to-target trial, and that whether or not Afrezza is approved for use, that would be both helpful and very important. And it's actually a complex issue because it's something that's needed to really confirm the ultimate efficacy in achieving targets with Afrezza. But the study design is one that needs to be very carefully thought through in terms of whether it should be looking at Afrezza on a background of basal insulin first, or whether another construct in terms of how insulin would be used. So whether there should be one trial or more than one trial, that's something that needs careful consideration, but would be very important whether or not the drug is approved. Would anyone like to make any corrections or additions to that? Dr. Samblin, yes.
I just want to clarify Dr. Wilson's point that in 175, there wasn't basal insulin provided. That was just oral agents with either placebo or, am I correct in that? So we can look at that as an example of what might happen if you inhaled this 2 or 3 times a day with oral agents, but in the absence of a glargine dose or something like that. Did I understand that correctly? There's no basal insulin in that study, right? 175.
That's my understanding. That's correct. I guess.
I'm not saying it's an ideal way to approach diabetes. I just want to.
Yeah, that's all. I agree with Dr. Shamblin, but that's in the context of a clinical trial with a lot of oversight, and having general internists and family physicians take a patient on one or two oral agents and then use this at will, ad hoc, isn't what we're thinking about, I believe, from our review of the literature.
Yeah, I agree with that as well. One thing I'd like to add to my comments is the point that as patients, a point that was made again by the panel was that, by a panel member, is that when patients reach the point at which they would benefit from transition to insulin, there is a potential for an inhaled insulin like this of making that an easier transition and an earlier in course implemented transition, and that as well could have benefit, although again that hasn't been rigorously studied. It remains a very reasonable possibility. Dr. Gauthier.
So I had a question because I think I'm hearing two things here. One was the fact that I think I heard that you think that this would be appropriate to be used as an add-on to a basal insulin. So that you would, am I hearing correctly, that you would prefer that this be reserved as after the basal insulin has been used, or are you saying that this is actually a good treatment option for a patient who needs insulin but doesn't want to inject insulin? That would be useful for us to.
I'll give you my answer, and then the panel can express other views, perhaps. I think that either of those is a possibility at this point, and I don't think we have the data that enable us to distinguish. And I would say that because I think the only way we can really know if there are, I don't think we know that there aren't patients who would benefit from initiation on an inhaled mealtime insulin on a background that does not include insulin therapy. The fact is that most patients start out on basal insulin when they go to insulin, and part of that may be convenience of that it's a once-a-day dosing, but there's a lot of data that supports improvement in A1C levels with that strategy. So one would not throw that out. That's sort of the most common circumstance on which one might envision this being utilized, and there would be concern if you took that away and only had this very rapid mealtime insulin as your source of insulin. So both of those they're not exclusive. And I think that's what you were asking. I don't know, other endocrinologists want to comment? Okay, so I think we will go to the next discussion question. And again, I'll read this discussion question 3. Discuss the pulmonary safety findings in the Afrezza clinical development program, acute bronchospasm and pulmonary function decline over time. A, comment as to whether the pulmonary safety data, 6 months with Gen 2 device and 2 years with Medtone device, are sufficient to address the pulmonary safety of Afrezza. And B, discuss your level of concern with the pulmonary risks. Dr. Calhoun.
Okay, thanks. I'll take a stab at a couple of those. Firstly, as I implied earlier, I don't think that the change in the device, unless there's something about this that we haven't heard, that the agency hasn't told us and that the sponsor hasn't told us, I don't think that the change in the device would be a reason to believe that there's a biologically different outcome. And so I guess I would look at the safety data as having a 2-year duration, not necessarily a 6-month duration, but having a 2-year duration. I don't think that that's entirely reassuring because 2 years is a relatively short time. And so one of the things that probably ought to be done if this comes to market is that people may be enrolled in a post-marketing registry, and you'll need to do that anyway for other things, but part of the registry could include serial pulmonary function tests. The data that exists suggests that the decline in pulmonary function test occurs early, is not progressive, and remits when the drug is stopped. But that's, again, in the context of a clinical trial, relatively short exposures, and so I think that that concern remains in the air. From the standpoint of the COPD folks, that diagnosis isn't trivial, but it's reasonably straightforward. If you have a spirometer and you can measure spirometry, the diagnosis of COPD, the presence of cigarette smoking, those things might be wrapped into that contraindication. The tougher issue is really that of asthma. And establishing a negative diagnosis of asthma is one of the things that pulmonologists and allergists struggle with quite a bit. So a history of asthma probably, if doctor diagnosed asthma, probably ought to meet the contraindication list. Abnormal lung function that has been documented in the past with reversibility or a positive challenge test in the past, which would be rare. But those would be things that would meet the criteria for asthma. But it does seem to me that there's a good bit of unrecognized asthma, and there's the potential, uncommon, perhaps what, 1 in 3 or 1 in 4, for pretty serious decrements in lung function. If asthma were to be unrecognized, the patient were to come in and begin taking the drug. So another thing you could do to mitigate that would be simply to have the first dose be monitored in the office, so that if there were to be some problem come up over the course of 10 or 15 minutes, there'd be trained personnel around who could deal with it. It would be a way of mitigating the risk. If it doesn't happen on the first dose, it probably isn't going to happen, because chances are pretty good that this is not an allergic reaction or an immunologic reaction, but rather a reaction due to the pH. And we're going to come back on the other question on the cancer risk, so we'll stop there. Thanks.
Yes, Dr. Stoller.
So I will speak to my assessment of the pulmonary safety. I guess I have a couple of concerns both inside the proposed labeling and outside the proposed labeling, and let me try to articulate what I mean. I agree with Dr. Calhoun's concern that, you know, the data suggests stability at 1 year. You know, when I look at the data, I'm not all that confident that there isn't a slope beyond 1 year to 2 years. And 37 ml per year in a normal individual over, 74 ml per year over 2 years is not a big deal. But if there is unrecognized lung disease, or even in normal individuals, played out over 20 years, this is conceivably a concern. So I'm just not satisfied that the FEV1 slopes are absolutely static from 1 year to 2 years based on the data that we've seen, and I would say that that frames some of the concern. The other concern I have is, if you will, outside the labeling. So if this were to be approved, it would come with a recommendation for spirometry as a precondition of prescription. I think that sounds very good and very easy, and in a real clinical context, it's really hard, really hard. Primary care physicians characteristically have not embraced spirometry. Guidelines have been conflicted about whether they should or not, in fairness to them. The quality of spirometry outside of controlled settings is often quite poor, usually favoring actually error, more disease present than absent, thankfully, but nonetheless it's inadequate. So patients could be denied therapy for inadequately performed spirometry, or in the converse, could overlook the spirometry contraindication. We know that the burden of undiagnosed COPD in this country is tremendous. There are more patients with COPD unrecognized than there are those that we treat in our offices. And the prevalence overall is about the same as diabetes mellitus. The estimates are about 20 to 25 million Americans affected. So if those individuals are inadvertently using a drug that we know would accelerate their rates of decline unrecognized, that's a concern. Again, it's outside the labeling. The labeling presumably would indicate spirometry as a mandatory precondition. I'm not confident that adherence with that is, it's very easy to say, it's very difficult to do, because the patterns of referral and all of that would undermine the ability to easily execute. I will say on the upside, that perhaps a mandatory requirement for spirometry would be a boon to the recognition of undiagnosed COPD to the extent to which it was done. So there is perhaps a potential upside in that regard, but on balance, I'd be more concerned about the downside than the upside in that risk.
Would the FDA want to make any comments about this issue of a mandatory spirometry requirement and kind of the realities of what one might anticipate?
Mia Paternetti, FDA. We have brought this point up in our discussions as well, especially given the prescribing environment, as you pointed out. This is not pulmonologists and allergists that could easily send their patient to get a spirometry. These are family practitioners, primary care, even endocrinologists at best, who still would have difficulty to access. So we have discussed this, and we've discussed ways that we could potentially deal with them, but at this point we're open to your thoughts and your level of concern regarding the matter.
Yeah, Dr. Swenson.
Well, my fine colleagues here raised most of the points I would raise, but adding to this testing before, I really worry about this reactivity issue, and perhaps bronchial provocation studies might be included, if only just in a follow-on brief period of time to define whether this drug really causes bronchial reactivity. And in terms of the issue of having pulmonary function testing data before initiating the treatment, some companies, it's a big step, but some companies demand certain things before the drug is released to a particular patient. It's quite burdensome, but it would be something to consider, that rather than letting the physician make the decision to have pulmonary function studies, that this be on the record that those studies exist.
So, Dr. Swenson, could I ask you for a little more clarity in terms of your concern about induction of bronchial reactivity, and would you envision, are you suggesting, or would you envision in a practical way the inclusion of some testing as part of the spirometry requirement, or more specifically, what would you think might be appropriate?
Well, maybe as a step ahead of just that would be for the company to deal with this issue, come to grips, determine over a period of time whether subjects develop any degree of bronchial hyperreactivity that might be mild and not picked up by either the patient themselves in terms of their daily dyspnea levels and breathing quality. And if there's no signal, then obviously I think the point is moot. But if a signal emerges, then some consideration of dealing with that possibility.
Yeah.
Mia Paternetti, FDA. I wanted to just comment that in the labeling recommendations, we are asking for spirometry to be assessed every 6 months. So it's possible so that if things occur over time, we might be able to pick up problems with hyperactivity that might occur over time.
Well, we just discussed the fact that if on the uptake, if they're not going to be done, they're probably more likely not to be done and follow up.
Yes, good point.
Yeah, Dr. Wilson.
So as a practical person in the clinic, if I'm going to start a patient on something like this, I'd like a test pack with the excipient all alone, or one of the very low-dose cartridges, and I have the patient try it while they're in the clinic. Or even take home a few very low cartridges before we really get into switching over to this new therapy. Because otherwise people come back 6 weeks, 2 months, and they've been trying this new therapy, and they said, I only took it for 5 days. I got all this tough coughing, and I stopped, and everything's out of control, so we waste time. So this was brought up earlier, and I was wondering whether our pulmonologists would go with my sort of approach, which would be the practical challenge the patient with a low dose or the excipient only in the clinic and not have to do extra testing. So.
And yes, Dr. Stoller.
Regrettably, I can't share enthusiasm for that strategy, only in that patients with chronic obstructive pulmonary disease might or might not experience, although they have in these studies, in the 8 patients on which we had PFT's data, they might or might not show some acute effects. But one would be concerned, this was certainly true in Exubera, that there was an incremental rate of decline compared to control in the patients with COPD. So you're now potentially accelerating the rate of decline of lung function over time in someone starting from a lower than expected baseline, and they might notice it. And if in fact the concerns about its being reversible are not assuaged, now you've done potentially irreversible harm. So I appreciate the practical approach. I just think it doesn't assuage my concerns about using it in undiagnosed COPD.
So I will try to summarize. Dr. Kelvin.
Yeah, so just to try to put this in a little framework, there are three concerns here that have come up. One is the one that Dr. Stoller just nicely articulated, that there's potentially an accelerated loss of lung function, which, if unrecognized, could end up being irreversible. That's concern number one. The second is a concern that Dr. Swenson mentioned, that there's the development, because of the irritant effect or whatever else is going on, of the development of airway hyperresponsiveness and so forth. And then the third concern is this acute bronchospasm that we saw in the safety data. And I think, to your point, Dr. Wilson, that last thing might be able to be addressed with a monitored first dose in the office. Because if you have a bronchospasm, at that point, this isn't the drug for you. But as Dr. Stoller nicely articulated, it doesn't assuage the second concern that we'd miss a progressive loss in pulmonary function, and I would agree with that. So I think it's important that pulmonary function testing probably serially be part of the expectation for people who get this drug.
All right, so this non-pulmonologist is going to try to summarize. So the panel importantly expressed the point that they did not see reason for particular concern about the impact of changing the device in terms of its effects on the safety data, that is not something of great concern to the panel members. There are a number of concerns expressed about potential pulmonary adverse effects of Afrezza. And one has to do with the potential for acute bronchospastic responses in patients who might have asthma, or patients who might otherwise respond to the drug acutely with potentially severe consequences. And one suggestion that was made to address this would be to have a first dose of the drug administered under supervision with adequate support to deal with an acute bronchospastic event. Concerns were expressed about more long-term effects, one of which might be a spread over time dependent induction of a bronchospastic response, a kind of sensitization to that response. And secondly, a concern about deterioration of pulmonary function over time, which may be extending over a very long period of time, and thus there was not comfort that the data available out to 2 years provide assurance that there might not, in a much longer period of time, be really clinically significant consequence of deteriorating pulmonary function. So it was felt important to evaluate patients with pulmonary function testing prior to use, as well as possible, addressing the issues of having that actually happen, and then follow-up pulmonary function testing over time as well. I heard no objection to the notion of every 6-month testing as a reasonable interval of time for that. And I'll ask my pulmonary colleagues if they would like to add anything to that summary. Wow, thank you. Now I just need to take the boards and I'm all set. Okay, we'll go on to discussion question number 4, which is discuss your level of concern with regard to the possible lung cancer risk with Afrezza use. Yes, Dr. Wozniak.
Well, I think that what I can safely say is I don't know. I think that, there were 4 cases in the Afrezza study. 2 were post-trial. And I suspect there were cases that weren't reported. So we're probably underestimating the number of cases, both on the treatment arm and on the comparator arm. That being said, there's still a little bit of a concern. The data from the Exubera trial indicated that there were 12 lung cancers and 3 on the comparator arms. The 12 were mostly smokers, but that doesn't exclude that having inhaled insulin might promote lung cancer in smokers. Not all of them get lung cancer. Could it do that? It's possible. There are actually insulin receptors in the lung, and the inhibition of these receptors actually has been the focus of a number of lung cancer therapeutic trials. They haven't worked out, but this is still an area of research. So that being said, because we don't really know what this is, if this drug comes to market, it's going to require a very robust observational study. And an observational study that will go on for a longer period of time because it takes a while to develop lung cancer. And you have a lot of patients on the trial, particularly the type 1 diabetics who are young, and it's going to take, they may be using the drug for a long time. And it's going to be important to collect patient demographics and smokers, passive smoking exposure, and all of these things to really figure it out. You can't just go by the SEER database because they don't collect smoking information. And the other thing I was going to mention, again, if this drug does come to market, that something has to be included in the product labeling post-approval to indicate that we are looking at risks of lung cancer.
Dr. Szabo.
So I'd like to echo that. There are a couple of things that were a little bit unusual. The 2 post-marketing cases were both squamous cells and non-smokers. If they truly were squamous and if they truly were non-smokers, that's sort of an unusual kind of pattern. The signal in former smokers from the Exubera trial, points to what is theoretically the concern here, which is promotion in the setting of prior initiation. So as Dr. Wozniak, I think, said very well, this is going to require a long post-marketing exploratory or follow-up, so to speak. I don't think we have enough information to feel confident that it's not an issue based on the short trials that were done in people who were just followed for a short period of time. We expect those cancers to be much later.